Okay. I would like to call the meeting to order and ask Ms. Cruz-Jones to take the roll.
Dr. Gonadev.
Here.
Dr. Hawkins.
Here.
Dr. Kraus.
Present.
Ms. Lawson.
Here.
Ms. Lubiano.
Here.
Dr. Lewis.
Present.
Dr. Mahmood.
Yes.
Dr. Thorpe.
Here.
Mr. Warmoth.
Here.
Mr. Watkins.
Present.
Dr. Yip. And Ms. Pines.
Here. We have a quorum. So now we're going to move to agenda item 15, which is a closed session. For those of you who have arrived here early, we're going into a closed session to consider the appointment or the employment of the executive director. This will take approximately 4 hours. There will be no teleconference during this portion of the meeting, and the line will be closed. You will be able to call back into the meeting once the closed session has ended, and you can monitor the status of this meeting on the board's webcast. We will now go into a closed session. Now we will resume open session. I am pleased to announce that during the closed session, the board voted to move forward with a candidate for executive director. This decision will be announced at a later date after pre-employment terms and conditions are finalized. I'd like to thank the board members for the search that we've done and for their due diligence on selecting what we believe is the ideal candidate. Thank you. Moving to agenda item 16, public comments on items not on the agenda. Before we invite speakers to come forward, I would ask that individuals making comments to not discuss pending complaints, pending licensing applications, or pending disciplinary actions that may come before the board for a decision. Such discussions are considered ex parte communications, as they could provide information to members that is outside the record and in violation of the Administrative Procedure Act. Therefore, such discussions could create a conflict and lead to the board decision being challenged in Superior Court. The board can receive comments regarding the board's process in general, but not comments on specific case circumstances where the decision is still pending. Board staff is available to speak with you about any pending matter. In addition, the board would like the public to address the board as a whole and not individual members. Please be aware that the public comment during this agenda item should provide us with information to the board members and is not a discussion between the board members and the public. The only action board members can take is to listen to comments and decide whether or not they want a future agenda item on the topic. No other action can be taken on the item at this meeting. Though this may seem at times to be like the board members are not being responsive, following these guidelines is critical to ensure that the rules of the Open Meeting Act are followed to avoid compromising the speaker's goals or the board's intent. Excuse me. So moving to the speaker slips that I have, the first one is Hannah Ree.
I push the button to turn on the green light. Okay. Yes, Hannah Ree here, Dr. Ree, Black Patients Matter, medical board members and executive committee. We at Black Patients Matter are very pleased to see significant improvements occurring within the HQIU investigative unit. Are pleased to see the investigative cases prepared in the AG's office. However, there is still a long way to go. Black Patients Matter calls for the NBC to vacate, withdraw all accusations and cases for which there exists evidence that a racial and religious bias was leveraged against the licensed physician. Justice reform is not limited to criminal cases, but must be extended to civil cases. I would also like to take this moment to reflect upon the unfortunate helicopter accident involving 9 people that occurred January 26, 2019 in the state of 2020 in the state of California. Rest in peace, Kobe Bryant. Rest in peace, Gianna Bryant. Rest in peace, Alyssa Altobelli. Rest in peace, John Altobelli. Rest in peace, Carrie Altobelli. Rest in peace, Christiana Masur. Rest in peace, Sarah Chester. Rest in peace, Peyton Chester. And rest in peace, pilot Era Zobayan. Thank you.
Thank you. Jose Luis Gonzalez.
Thank you, Madam Chair, members of the board. My name is Jose Gonzalez. I'm the Executive Director for the Association of Northern California Oncologists, and I here represent our membership as well as those of the Medical Oncology Association of Southern California. Our purpose is to inform you that we'll be introducing legislation this year authored by Senator Rubio entitled the Cancer Medication Recycling Act. And we'll be cooperating with the American Cancer Society in this effort. The act would create a framework to allow cancer patients to donate their unused oral anti-cancer medications to their prescribing physicians for use with other patients needing the same medication. These programs would be regulated by the Medical Board of California. What is the problem the act is trying to address? Oral anti-cancer medications, as you know, are very expensive, and it often takes months for patients to access these medications and begin treatment. Some patients must stop taking their medications due to ineffectiveness or intolerance. As it stands now, this results in unused, unneeded, expensive oral anti-cancer medications being discarded by the patient. ANCO and MOASC would rather see these valuable resources returned to the prescribing physician and reused with new patients in need of these medications immediately. We're trying to avert the waste of expensive anti-cancer medications and minimize the time patients needing those medications have to wait for them. Our goal is to have more cancer patients in California have access to their needed medications in a timely manner and reduce the amount of anti-cancer medications that are wasted. In California, existing law does allow counties to establish programs to dispense donated unused medications. Unfortunately, cancer medications are not included in many of these programs, and these programs are generally very limited. Elsewhere in the country, 21 states have active drug donation and reuse programs serving thousands of patients. 14 states have successfully implemented anti-cancer medication recycling programs. In New Mexico, specifically, a model program spearheaded by the immediate past president of the American Medical Association, who is a medical oncologist, has recycled more than $300,000 worth of medication at her practice in 2018 alone with no adverse effects, and there have been no reported adverse events or patient harm in any of the states with current programs. Our proposed act would require physicians to inspect all donated medications to determine that they are unadulterated, safe, and suitable for redistribution. The donated medication expiration dates must be at least 6 months away. Donors must be already patients of the prescribing physician on record. And physicians would ensure that all donated medications are stored in compliance with the manufacturer's requirements and comply with all FDA drug recall and safety alerts. Liability language to ensure patient donors and physicians have adequate liability protection while ensuring both are incentivized to accurately describe the status of the donated medication would be included in the act. So we look forward to working with the board in developing this legislation and moving it forward. Thank you very much.
Thank you. Ms. Short?
Thank you so much for having me. Nisette Short, I am following up on that presentation by Mr. Gonzalez. I'm the legislative advocate for the Association of Northern California Oncologists and the Medical Oncology Association of Southern California. I just want to take the opportunity to thank your staff for the technical assistance that they've provided us so far, and thank our friends at the California Medical Association for the technical assistance they provided us on the liability issues. And we look forward to working with you all as we work to get the bill through the process. Thank you.
Thank you. Andrea Hedstrom?
Push a button. All right, members of the board, you're an impressive-looking group. Thank you for having me today. I will admit I have never in my life done anything like this. But I'm here because, as a mother, I am kind of the voice in this moment for what I feel is a really important unrepresented group in our society. CDC's autism rate is 1 in 59. This is a horrifying number. And this report is based on data collected in 2014. This statistic is already outdated by 6 years and only includes 11 small states, not including California. According to California Department of Education in 2018 data, 1 out of 32 students ages 4 to 6 years of age enrolled in school have autism. This is an epidemic of catastrophic proportions. And here are some more startling numbers. The average rise of autism is 10 to 15% per year. Citing UC Davis's J. Paul Lee 2015 study in his cost analysis, a political economist states, at the current trajectory, in 2025, autism will cost the United States $1 trillion per year. So what numbers do you need to motivate everyone to find the cause to prevent future cases? At this rate, it is either autism prevention or economic collapse of this country. UC Davis is one of the leading autism research universities in this country. However, the studies are peripheral and do not tend to address the cause of autism. They are not addressing the one area that healthcare consumers and some expert scientists are pointing to: aluminum adjuvants. Researchers will benefit to follow the lead of these prominent scientists. Children receive up to 4,925 micrograms of aluminum adjuvants by 18 months of age. This exposure should not be ignored. I can name several recent studies that do associate aluminum adjuvants and autism. 2009 Shaw study, aluminum hydroxide injections lead to motor deficits and motor neuron degeneration. And 2011 Shaw study, do aluminum vaccine adjuvants contribute to the rising prevalence of autism? Please conclude. So my daughter would like 3 minutes to finish. She's another independent person. Can she finish with the 3 minutes? She's prepared to speak.
Anyone can speak. Anyone has 3 minutes.
Okay, so Audrey, can you come and finish, please? Dr. Exley's study.
Dr. Exley's study, Aluminum in Brain Tissue in Autism. Leon Whaler's study, Reconsideration of the Immunotherapeutic Pediatric Safe Dose Levels of Aluminum. 2020 Leon's, Weiler, and Thomas study, Acute Exposure and Chronic Retention of Aluminum in 3 Vaccine Schedules and Effects of Genetic and Environmental Variation. UC Davis Mind Institute states they do not believe that investing in vaccine research is a productive use of limited sources. They cite a few studies regarding one vaccine, MMR, and rubella productive use of rubella-induced autism. But to simply repeat older literature while ignoring very recent research is not responsible. Autism rates are soaring with no end in sight. It is not sufficient to isolate one shot, the MMR, while ignoring the compounding impact of 68 other doses that contain problematic adjuvants. These are signals to investigate. There is enough scientific evidence to stop vilifying doctors and scientists that are investigating these signals. As the protectors of the health care consumer, it is the obligation of the medical board to utilize all your resources to find the cause and prevention of more cases. It is not just our children, it's your children and grandchildren that will be affected. We all need to help stop this epidemic. 1 in 32 kids in California have autism. We are out of time.
Thank you. Eric Andrus.
I have to talk fast. I have a lot to say. I just wanted on the record that I sent 2 emails to Denise trying to get information on the interested parties meeting and CC'd all of you and never received a single reply. I just confronted Christine Lally and asked her why, and her response was, "I think you know why," which confirms a concerted effort to not work with me. And I've been told that Miss Paranoid Kimberly Kirkmeyer, who now appears to be using her new position to harass medical board employees, trying to find out who's telling me things and trying to instill fear into workers who would like to do the right thing, that no one is to correspond with me. All of these little childish antics like this make for our time at these meetings that much more unproductive and unpleasant and forces me to call you out at these meetings. Don't you see that your unprofessional tactics are not working? We were given next to no information on the upcoming interested parties meeting. We have no idea how many people are coming or how long we were going to have to speak. We had no way of knowing what or how much to prepare, so you've already set this meeting up for failure. Along with what I told you yesterday about your lazy employee, here's another example of our website being better than Breeze. On your website, you show Dr. George Jefferson Thomas as delinquent. He's actually been dead since June 14th, 2016. His obituary is on our website. Do you not let your employees use Google? Our website would be invaluable for this board if you weren't so belligerent about associating with us. Interesting trivia, our website cost me $50 to design. What was Breeze's cost again? According to the state auditor as of 2015, over $96 million. And Kimberly Kirkmeyer, if you continue to harass employees illegally, we will do everything in our power to report you to the proper authorities and get it reported in the press. No one should be made to fear reporting wrongdoing in their workplace, like the brave medical board employee who reported the sexual harassment by her supervisor that Kimberly Kirkmeyer tried to cover up and make go away. So Ron, were you aware of any of this when you were sobbing over Kim's departure, or do you just approve of the tactics? For a small group of citizens who have been doing wrong by this board multiple times now, I think we're doing a hell of a job in investigating you all and exposing it. Just ask Dev. Google his name and you'll see our investigation of him on Kaiser Health News right at the top of the list. One day we're going to get to the right person to listen. David Warmoth once accused us of possibly being on a vendetta. But think about it. Can any of you really blame us? A doctor killed my sister. You refused to investigate, letting him go free. I brought you emphatic evidence that a doctor did hernia surgery on me twice, wrong, and you closed my complaint. A doctor who just had a hearing here yesterday overdosed Marion's dad, sending him on a spiral to death. She warned you about him, and you didn't listen. Now his actions led to another person's death. Dr. Daniel Hedrick overdosed him and Tammy Smick's son to death, and you gave him a slap on the wrist public reprimand. Annette Ramirez lost all of her arms and legs due to doctor errors, and you closed her complaint as well. And I can go on and on. That's not patient safety, folks. That's incompetence by this board. And you're all sitting back, allowing it to happen, which makes you all accomplices.
Thank you. Wendy Ketch.
Hi. Thank you for giving me the opportunity to speak. I think by now you all might be familiar with the legislation that we're bringing forth with Center for Public Interest Law. And it's a law that addresses ethics in medicine, making doctors accountable to patients by disclosing conflicts of interest that may affect their care. I was hoping today to give you our author. It's imminent, but don't have it just yet. The legislation would make it mandatory for doctors to disclose payments from drug and device companies directly to patients. The law is not intended to discourage a doctor's involvement in drug or device trials or research, but to allow the patient to have fully informed consent. It is a proven fact that money given to drug and device companies for participation in trials, prescribing medication, and promoting their products can, in fact, influence a doctor's judgment and can create conflicts of interest. Decisions can be made that are not in the patient's best interest. A simple disclosure of payments given directly by doctors to patients is logical and the right thing to do. Patients must currently be informed when doctors have ownership in facilities that they use that involve their treatment. So why shouldn't they also be informed about monies received for trials, research, and promotions? Patients have the right to know, and this transparency would also improve trust between the doctor and the patient, as many doctors have attested to. All patients have a right to informed consent, and without the knowledge of these payments, patients cannot make an informed decision about their treatment. I urge the board to support our legislation and to make ethics in medicine a priority. Thank you.
Thank you. Are there any questions or comments, rather, on the phone?
Have any comments from Faith and Lawrence?
Hi, before I speak, I'd like to let you know that the phone line has been really painful today. The feedback, it was screeching loud. So now I'd like to start speaking, but I would appreciate if you can troubleshoot that for next time. Thank you. Okay, I'm starting now. I was an athletic person when I went to Sahlberger for medically indicated breast reduction. In his private surgery center, Berger committed a disabling assault from my waist to my shins while he had me under anesthesia. He went against legal consent. His actions, such as stabbing my IT bands, hamstrings, sciatic notch, and more, were not valid medical procedures. His negligence constitutes assault. The medical board let Berger go scot-free. Claims of harm continue to come in from other women. Medical records are often incorrect, even with audit trails, which I didn't get, but even with them, because doctors make up whatever suits them in real time. Batterers do not document the harm they do, but they fabricate notes, alter records, and blame and slander a victim, and that leads to ongoing medical harm. Negligent doctors mistreated me until I got outside of Berger's sphere and to a responsible physician who actually examined my body. I wrote the Department of Consumer Affairs about the failure of the medical board. They sent me a document filled with fraud. Christina Delp, former director of enforcement, urged me to take this case of battery to the police and DA. But law enforcement told me that medical battery is outside of their purview unless the medical board tells them to investigate. Since there is no one doing real investigations, this puts your doctors above the law, and Californians are suffering for it. Kim Kirchmeyer, former executive director of the medical board and now DCA director, gaslit me. She called facts my beliefs, which is a common tactic. By the way, the line is screeching again, the phone line. It's a common tactic medical watchdogs do to invalidate malpractice victims. The gaslighting and denial of medical atrocities by your board is sadistic and it's cruel. It greatly compounds the damage to malpractice victims, and I'm asking you to stop it. Many plastic surgeons in California violate people and cover up for each other. Your board acts as though surgeries that remove part of healthy endocrine organs that are done for no justifiable medical reason and or include assault are normal. They're not. They're crimes that cause a spectrum of problems, and it's time that we face it. In May 2019, 49 of 55 members of the Los Angeles Society of Plastic Surgeons had multiple, easily searchable, desperate reviews. all liposuction-related deaths in Los Angeles from 1999 to 2019 were to females, average age under 48. I read you the list yesterday. This is gender-related medical violence, and the state of California sanctions this. I ask that you learn the biology of fat. I've given you plenty of information, and the health structure and contour problems caused by liposuction or other non-surgical fat-altering procedures. Stop gaslighting victims, stop bad surgeons, stop medical scams, and we need to do something about the fact that your board and the DCA are interconnected and sent me fraudulent documents. Meanwhile, the doctor who harmed me continues to work. So you're not meeting your statutory your mission. You're failing. I'm not here just to call you out and to point a finger.
Please conclude.
I'm here to protect people like I wasn't protected. Thank you.
Thank you.
No further comments on the phone.
Okay, we're having a little bit of technical problems, but we're going to move forward because we have quite a few things still left on our agenda. So I'm going to skip from item 17 for a moment to item 19, an update on autism research. Dr. Hansen. Dr. Hansen is a professor of pediatrics at the University of California, Davis, and we would like to welcome her to the medical board.
Before that. No, it's the first one, not that one. Yeah.
All this technology.
There you go.
Thank you. Well, thank you. It's a privilege to be here, and I appreciate the opportunity. Oh, thank you. I appreciate the opportunity to share some of the work that we're doing at the UC Davis Mind Institute to try and understand the increasing prevalence that you heard about just earlier in autism spectrum disorders. So Jennifer asked me to cover information about the prevalence of autism, how we make the diagnosis, some of our understanding about the causes, potential etiologies of autism, the comorbidities associated with autism, some treatment, evidence-based treatments, and to try and weave into all of those some of the research that we are doing at the Mind Institute. So as you heard before, there's been a 7-fold increase in the prevalence of autism spectrum disorders. Moving too fast. Over the last 2 decades. And clearly this is something that we have been trying to understand in the context of what we know and don't know about autism spectrum disorders. So as you can see, it was 1 in 68 in 2016, and that the prevalence most recently is more like 1 in 59, which comes out to about 1.7% of the childhood population in the United States. And as was stated earlier, this is based on a very systematic study through the CDC that has been going on for many, many years and using the same strategy over that same time period and in representative populations across the United States. We also know that in addition to the increasing prevalence, it's much more common in boys, and across this increasing prevalence, the ratio of males to females with a diagnosis of autism has continued to be about 4-to-1. So how do we diagnose autism? One of the questions has been, is the increasing prevalence that we are seeing somehow due to diagnosing it differently? Are we changing our diagnostic criteria? So currently we are using the Diagnostic and Statistical Manual, 5th edition. There have been some changes. We used to have sort of different diagnostic differences across the diagnosis of autism. So we had autistic disorder, Asperger's disorder, and pervasive developmental disorder not otherwise specified. And because of the information and the research that was done on how well do experts who make the diagnosis as part of research and as part of their clinical practice make those distinctions, it was decided in this most recent version that we currently use for diagnosis to not have those distinct differences across the spectrum, but to use a diagnosis of an autism spectrum disorder. So it's based on 2 components. They are determined both by taking a very long history about behavioral concerns, changes in developmental trajectories, and also by observation. There are some standardized observation measures, many of which are used clinically, clearly used in the prevalence, some of the prevalence studies, and also in our research studies. So these are the 2 main criteria, diagnostic areas that we are obtaining history and basing our observations of child and adult behaviors. So impairments in social communication and interaction. So individuals with a diagnosis on the autism spectrum are required to have impairments in all 3 of these categories: social emotional reciprocity, deficits in nonverbal communication, and deficits in developing, maintaining, and understanding relationships. So how these impairments look over time clearly is different from young children to older children, adolescents, and adults. So clearly some of the findings will change over time, but deficits in social emotional reciprocity would be examples would be difficulties interacting or maintaining social conversations or interactions, avoiding social interactions. Deficits in nonverbal communication would be difficulties with using and understanding gestural communication, making eye contact. And deficits in developing and maintaining social relationships would be relationships with both peers and caregivers and other people in their environments. The second category is restricted, repetitive patterns of behavior and interests. And for a diagnosis, individuals need to have impairments in 2 of the 4 of these. So restricted, stereotyped, repetitive motor movements, or stereotypies in speech, or difficulties with ritualized speech, excessive insistence on sameness, routines and rituals, difficulties when things change, highly restricted interests, and hyper or hyposensitivity to sensory input, such as high thresholds for pain, difficulties or atypical sensitivity, such as difficulties with different kinds of foods, smells, those kinds of things. These symptoms have to be present early in childhood, although they may not become apparent and manifest in terms of significant impairments until children get older and the social demands are sort of exceeding their capacities in all of these areas. And as we said, these symptoms must limit and impair many aspects of functioning. So we do know that autism spectrum disorders have a strong genetic component. There is an increased risk if there's one child who has autism in the family, that the next children are certainly at greater risk than the general population, somewhere as high as at least 30%. Some studies have suggested that it may be up to 50%. If you're an identical twin, there's a 90% risk that if one twin is on the spectrum, that the other one will be as well. And we also know that there are less impaired, what we call phenotypes, of family members who don't meet the criteria for an autism spectrum disorder, but do perhaps have some social deficits, social struggles that they have, maybe have sensory kinds of issues, and tend to have more restricted in behavioral interests. I don't know why this keeps going without me pushing it. We do know that autism spectrum disorders are not caused by poor parenting. And we also know that they are present across all social classes and all racial groups. And these prevalence factors in the countries that we do know, so internationally, the prevalence of autism seems to be increasing with the data that we have. So I just wanted to kind of set the context for how we have been thinking about addressing the issues through our research at the Mind Institute in terms of how do we understand this increasing prevalence in something that we know is highly heritable, but that we know that genetic disorders don't change all that fast. So we've kind of conceptualized it in terms of that there probably are different multiple paths and different etiologies to get to a diagnosis of an autism spectrum disorder. And one way to conceptualize it is to think that there are some types of autism or etiologies of autism that are very highly related to genetic differences. So we might call that autism type A. And as an example, we know that the majority of children and adults who have a genetic disorder called Fragile X syndrome also have a diagnosis of autism spectrum disorder, and many symptoms that overlap even if they don't meet the full criteria. And then there seems like there is sort of another potential group of individuals with autism spectrum disorders that have genetic vulnerabilities that don't manifest necessarily as autism until there's an environmental trigger. I will give you some examples of that, but that might be sort of what we could consider conceptually autism type B. And then another type that seems to be much more purely environmental, such as children with prenatal valproate exposure or with congenital rubella. This is just another way of looking at what we know now fairly recently. This was 2016 study, but really the differences and the components of genetic risk, its overlap and its interaction with environmental risk factors that make certain genetic profiles more susceptible to environmental impacts. So you can see that, in some studies we've seen that about 50% of autism risk or intellectual disability may be related to very common variants that are found across the population, but that depending on those combinations of common variants may have a genetic profile that increases your risk for atypical early fetal development and early brain development. Epigenetic factors we're learning much more about, where the genes themselves don't change, but whether they are turned on and when they are turned on or turned off have very important roles to play in how early brain development occurs. And then the contribution of environmental factors. So we have multiple studies that have been going on for the last, some of these for 20 years, looking at exactly this, gene-environment interactions, and how do we understand specific genetic susceptibilities and specific environmental exposures that may join together to increase autism risk. So I will talk about some of the research from both of these studies. One of them is called Childhood Autism Risk from Genes and the Environment, which we call the CHARGE study. And the other one is, and this is a retrospective study, and the Markers of Autism Risk in Babies, Learning Early Signs, we call the MARBLE study. But both of these studies really look in different, using retrospective and prospective strategies to look at large groups of children who have autism or at risk for autism in marbles, children who don't have autism, and comparing what is their history, what do we know about their genetic backgrounds, what do we know about their family histories, what do we know about their exposures during their mother's exposure during pregnancy to potential environmental risk factors, and how does that help us understand the contributions of both gene and environment interactions. So let me just start with a couple of our studies that I think help illustrate what we're beginning to understand. And we've done several studies looking at whether preconception and prenatal folate is protective for autism spectrum disorders, and specifically looked at folate because there's good evidence for many, many decades that folate is important for preventing neural tube defects. And what we found is that particularly for women and children who have a genetic variant which has no symptoms, but just means that they are somewhat slower in metabolizing folate, which is important in several metabolic pathways, that it's particularly important for slow metabolizers to have preconception and early prenatal folate exposure in terms of protecting them and their children from autism. So again, this was really, I think, our most clear and early on gene-environment interaction study to show how we can modulate genetic risk through in the environment in a protective way, so reducing autism risk. Several studies that we did looked at the maternal environment, particularly looking at components of maternal prenatal health that related to inflammation. So maternal obesity, preeclampsia, metabolic syndrome, hypertension, diabetes during pregnancy do seem to be associated with autism risk and also increase the risk of intellectual disability without autism. And we think that the common mechanisms underlying all of these health conditions during pregnancy are that they are associated with chronic and increased levels of inflammatory markers, potentially oxidative stress, and also we think that there is a vulnerability to women who have these conditions during pregnancy to develop autoantibodies and antibodies that target specific brain proteins in early fetal brain. So I wanted to then take that a little bit further and walk you through a study that started out in the CHARGE study as sort of a clinical finding of unknown significance that has led us to do testing of a mechanistic model in animals and then looking back at sort of the phenotypic findings in children whose mothers have these antibodies. So I'm having a hard time seeing this. So what we found is that there are some mothers who during pregnancy have developed antibodies that react to human proteins. These are IgG antibodies, so they can cross the placenta. And in our animal models, we have found that they target specifically fetal brain proteins. And this is just a study in a monkey brain model where you can see these antibodies are targeting brain proteins and that they impact the development of the dendrites. So you can see that they're much thinner in the ones that have been exposed to antibodies. And then what we found is that in our population of mothers, about 26% of mothers have these antibodies. We find these antibodies in mothers whose children have autism and very, very rarely in mothers who have children without autism. So I think this is a fairly specific biomarker for autism risk. We've also found that the children born to these mothers, in addition to having autism, that they tend to have more severe behavioral impairments. They have more pronounced stereotypical behaviors, repetitive motor movements. And we're not sure about the mechanism for this, but they tend to have larger brain volumes, which has been associated with other types of autism as well. So again, it's a way that we have found that suggests that inflammation and specific immune dysregulation may be playing a contributing factor in some children's autism. So I also wanted to just address some of the other comorbid or related findings that we see in children who have a diagnosis on the autism spectrum. One of these is intellectual disability. So around 40 to 50% of children with a diagnosis of autism will also have a diagnosis of intellectual disability. Part of the diagnosis is that you have potentially hypo and hypersensitivity and sensory differences. ADHD used to not be a coexisting diagnosis because our criteria until the DSM-5 was that if you had autism, you couldn't also have a diagnosis of ADHD, and clinically we knew that that clearly was possible. So in DSM-5 you can have both of these as coexisting diagnoses, and it frequently is true. Learning disabilities, anxiety, and depression are also quite common, particularly in older children and adults with autism spectrum disorders. Tics and Tourette syndrome are sometimes associated, as well as other genetic disorders. So just in terms of sort of the medical workup, once an autism diagnosis is made, we want to make sure that hearing and vision are completely intact and are not contributing to some of the impairments that we're seeing. Clearly do a good physical exam and history, looking for any suggestion of seizures, asking about sleep problems, asking about GI problems, which we find are often co-occurring in children with autism. Deciding on the appropriate genetic testing to make sure, see if we can identify what we think might be a contributing risk factor, and etiology, and also, as I said, address the comorbidities that are associated with it. So quickly, just talking about treatment. At this point, behavioral and educational treatments are the most effective for the core symptoms of autism. We currently don't have medications or medical treatments that address the core symptoms of autism. We have a lot of behavioral and educational interventions that have a good evidence base for their effectiveness. And so this really is, I think, the standard of care. I think it's clear that the earlier that we start behavioral interventions, the more effective they are. And also that it's very important that parents are part of the intervention team. This is just a study that Sally Rogers, who's one of our psychologists at the Mine Institute, was part of,
developing an evidence-based behavioral treatment called the Early Start Denver model. But I think the importance of this is that this behavioral intervention was associated with normalizing brain activity on evoked related potentials in children who had received the Early Start Denver model compared to children who had received non-evidence-based community treatments. So again, I think that we clearly have the capacity to change both structure and function with using behavioral treatments. These are just other treatments that are often important for children on the autism spectrum. I'm not really going to go into too much of those, just in the interest of time. But really, I just wanted to summarize that we know that autism spectrum disorders are biologically based disorders that are not created by poor parenting. We do make the diagnosis through behavioral assessments, and currently there are no specific medical tests to diagnose autism, and that early behavioral interventions are the most effective treatments available and fortunately now covered by insurances. And then just to say that, for our future research challenges are really to continue to think broadly about environmental contributors to risk that might be modifiable, that it's important that we continue doing collaborative and interdisciplinary research that links the clinical and biomedical phenotyping to understand the complex heterogeneity of autism, and to really continue to look at gene environment data to develop more targeted biomedical treatments. So I'll stop there, and I'm happy to answer questions.
Thank you, Dr. Hansen. I really appreciate that thorough report. It was insightful. I learned a few things. I do have a question about, you said that more males than females, but there wasn't a breakdown of ethnicities. If there is some sort of trend there that's evolving now that this number is growing. Can you speak to that?
So I think your question is the ratio 4-to-1 in males similar across racial and ethnic groups? And I think that's true.
Okay.
Yeah, I think that's true. I think where we struggle is that children from underrepresented or under-resourced groups tend to get a diagnosis later and tend to be less involved in many research studies. So I think we have less data.
Okay.
But as far as we know, there don't seem to be any differences in that sex difference between males and females and their vulnerability across groups.
Okay, and then one last question. Earliest studies, do you know what the earliest studies on autism were? What year, generally?
Well, gosh. I think it was 1943 when the first diagnosis, was reported as and described in the literature. Mm-hmm. And I think the original thoughts were that it was a biologically based disorder, and then that thinking sort of changed, and it became more that it was a result of poor parenting. Mm-hmm. And so then we've now come back to understanding it as a biologically based disorder.
Okay. Dr. Gananade?
Dr. Hansen, thank you for coming. With the incidence increasing so much, what are the preventive measures by your research, whether it is preconception, during conception, after birth, with the environment, because this is going to be one of the biggest human problems, as you can see, so socially and also economically. Yeah. So that's why there is a lot of commotion among public. So. Yes. Can you tell us what can we get there?
I think we should be concerned, and I think that concerned not only about autism, but also about other neurodevelopmental disorders that we think are influenced by the environment. So some studies that I didn't focus on, but that we've completed as part of the CHARGE and the MARBLE study, are that we know that exposure to air pollution exposure to pesticides, such as insecticides in the home, are associated with increased autism risk, particularly during pregnancy. One thing I forgot to mention when I was discussing the folate study is that we found that prenatal and preconceptual folate seemed to mitigate the risk for autism in women who were exposed to household pesticides during their pregnancy. So women who had high levels of folate throughout their pregnancy and no pesticide exposure were sort of the control group, and then women who had folate and pesticide exposure, women who had no folate and no pesticide exposure, and then women who had folate and pesticide exposure, no folate and pesticide exposure were at the greatest risk, and it was just linear like that. So folate does seem to be very protective, both for sort of what we've called genetically susceptible normal variants, but also for women who have environmental exposures like pesticides, like air pollution. Some of these you can't modify. You know, if you live near a freeway, it's hard, that's where you live, and we know that that's a risk factor. So folate during pregnancy and before you're pregnant, I think is something that's a public health measure that we think modifies autism risk. I think that being much more aware of maternal health factors, hypertension, gestational diabetes, overweight and obesity, these are all factors that we think increase risk. So we should be very aware of trying to help women address those issues before they get pregnant. So again, there are some things that are modifiable and, you know, in our own personal lives and as physicians. But I also think as a society, we really need to be addressing issues around pesticide exposure of children and mothers, and just good public health measures.
Ms. Lubiano?
Thank you.
You're welcome.
I appreciated the slide about the future research challenges and wanted to dive into that a little bit more in terms of, could you provide some insight into perhaps what could drive this further? You know, if you had unlimited time and resources, would it be, you know, do you need more patients? Is it more qualified individuals such as yourselves? Is there a lack of that who are interested in this area? Or is it lack of funding? What could drive getting more helpful information?
That's a tough question. You know, I think there are lots of centers across the United States and internationally that are trying to tackle this problem. I think that we have our best shot at coming up with more and more answers if we work together and we collaborate. So I think one of the concerns that we have sometimes is that people work in silos. I think the other thing that's really important is to make sure that we have connections between the clinical piece with clinicians and sort of the basic biology research, animal models, that these are connected. And that's why I just use the example of how we work through a clinical finding, took it to a mouse model, and then brought it back into clinic. And I think that in terms of an area of research that may have significant impact. So if 26% of children, at least in our population, and we've started to look across the country in other populations to see whether these antibodies in mothers are similar or whether somehow they're unique to California. It seems like they probably aren't. But if we could identify a way to, to do easy screening for mothers who do have these antibodies, and just like with Rh negative, to identify moms who are at risk for having sending antibodies to their children, to like ROGAM, to have something that would prevent those complex with those antibodies in the mother and prevent them from crossing over the placenta into the fetal circulation. if we could prevent 26% of autism spectrum disorders, that would be significant. So I think that's an area of research that we are really trying to put a lot of our energy in. So it's one example.
Thank you.
Dr. Krause?
Thank you for the work that you're doing. Personally and professionally, I've known many autistic children and adults, and I'd like to emphasize the word spectrum. And the spectrum also includes some very positive things.
Yes.
Some of the most brilliant scientists, mathematicians, physicists, artists I've known have been on the spectrum. So certainly profound autism and a level of a spectrum disorder that interferes with social interaction and education is something that needs our attention. But I'm not sure I would want to wipe out the entirety of the spectrum, because there are comorbidities, but there are also excellent
Thank
features.
you for bringing that up. And I think that is another area that we as a society truly need to recognize, that the importance of neurodiversity. And you're absolutely right. Celebrating the strengths of people who are on the spectrum.
And the other thing I'd like to add...
all ends of the spectrum.
The other thing I'd like to add, which is true of science in general, is just as I read one day that coffee will kill you and the next day that coffee will extend your lifespan, we have to be cautious not to go from an association to a conclusion of cause and effect. And similarly, since we know that although it may be a mix of genetic and environmental factors, we shouldn't overlook the genetic factors. So when we find that 26% of women carry MAR with a much higher incidence of having autistic children, the other part of that study is we have to evaluate the mothers to see what percent of mothers are on the spectrum versus not on the spectrum. And similar to exposure to pesticides and pollutants, I'm not in favor of exposure to those things. But if the factor is such that people who are suffering as adults from being on the spectrum are also at an economic disadvantage and therefore at an environmental disadvantage, there's an important factor that needs to be studied there.
So
the best that should be done with an association or a retrospective analysis should be to create a hypothesis that then needs to be scientifically studied.
I totally agree with that.
Dr. Hawkins?
Yes, thanks again. So as far as we can tell now, this is a behavioral-based diagnosis, and we don't have, and I understand the heterogeneity, and Dr. Krause just mentioned that, and it's on your slide, that we don't think this is just a one thing causing the spectrum. The best we can do now is behavioral-based diagnosis. Is that accurate? We don't have...
Yes. By definition, it's a behavioral-based diagnosis, right?
Okay.
So it's we're sort of stuck with the way we've described it. It's a behavioral diagnosis. So I think there are many, many studies that have looked at... a study just came out looking at saliva samples and genetic risk profiles for autism, but they're not diagnostic of autism. So I would just give you an example, say Down syndrome. So clearly that's a genetic disorder, and children with Down syndrome are at a higher risk of also having autism than children who don't have Down syndrome. So it's much higher than the normal population. But most children with Down syndrome and adults are not on the autism spectrum. So again, it's like, what is different about children with Down syndrome who have autism genetically and children, or environmentally, and children with Down syndrome who don't have autism? So I think every time we find sort of risk markers, they are just that. They're not diagnostic. They increase your risk. So I think that's, and I think that's partly why autism is so complicated and hard to feel like we understand what can we do about this, and why is the prevalence increasing so fast, and why it feels like such an emergency.
So, and just two other things. One was the folic acid, and we just determined that folic acid deficiency led to neural tube defects. It became part of all multivitamins. Can you elaborate on whether we think folic acid should be in higher doses in
Well,
prenatal vitamins?
we are recommending that every woman of childbearing age should be on increased folate, whether that's just taking prenatal vitamins, but it's a modifiable risk factor, particularly if you're a slow metabolizer, and who knows? Nobody knows because we don't test for that routinely. So as a public health measure, I think the word that we would like to get out is, all women of childbearing age, whether you're planning to get pregnant or not, should be on extra folate.
Thank you.
You're welcome.
Any additional questions from members? Okay. Dr. Hansen, thank you so much.
Thank you very much. I appreciate your time.
I appreciate your time. Margot? No, please come up. This one? Yes.
She's Margot.
Okay.
Margaret.
Okay, Margot.
This was Margaret.
Margot.
There you go, Margot. Put your microphone down. Remember? Pull it over.
Thank you, Dr. Hansen, for your presentation. CDC's autism rate is 1 in 59. This statistic is already outdated by 6 years and only includes 11 small states, not including California. According to California's Department of Education data, 1 out of 32 students ages 4 to 6 years have autism. In 2025, autism will cost the United States $1 trillion. At this point, it is either autism prevention or economic collapse of this country. As the protectors of the health care consumer, it is your obligation to utilize all your resources to find the cause and prevention of more cases. It is not just your children, it's our children. It's your children and grandchildren that will be affected. Children receive up to 4,925 micrograms of aluminum adjuvants by 18 months of age. This exposure should not be ignored. 1 in 32 kids in California have autism. We are out of time.
Thank you. Mary Ann Hollingsworth.
Hello, my name is Marian Hollingsworth, a patient safety advocate. I'd like to thank Dr. Hansen for her report on autism, and I would also like to request that this report be put on the medical board website under the materials for this agenda item. I know I'm interested in looking it over further. I know I have family members who would be interested, including a sister-in-law who's a principal and a special ed teacher who would find that interesting. And while we're at it, would it be possible to have some type of requirement that materials be posted online like 48 hours ahead of the meeting so that everyone, board members and public alike would be able to look over? That way we can study the materials and formulate any questions or comments we might have. I think that would be helpful. I know it is printed in the back, but at the time that this presentation started, it was still not online. So I know of somebody at home in Southern California who was looking for it. So it would just be helpful if that would be a requirement, just so it would be available for people if they're interested. So thank you.
Thank you. Any additional comments in the audience? Any comments on the phone?
Yes. One moment, please. We do have a comment from Susan Lauren.
Hi, my name is Susan Lauren. I called before, but I got word that my comment was inaudible. The sound system was so bad, I couldn't hear what was being said, and I couldn't be heard, and I'd like to give my public comment now.
Yes.
Thank you. I was an athletic person when I went to Saul Berger for medically indicated breast reduction. In his private surgery center, Berger committed a disabling assault from my waist to shins while he had me under anesthesia. He went against need and consent. His actions, such as stabbing my iliotibial bands, hamstrings, sciatic notch, and more, were not valid medical procedures. His negligence constitutes assault. The medical board let Berger go scot-free. Claims of harm continue to come in from other women. Medical records are often incorrect, even with audit trails, because doctors make up whatever suits them in real time. Batterers do not document the harm they do, but they do fabricate notes, alter records, and blame and slander a victim that leads to ongoing harm. Negligent doctors mistreated me until I got outside of Berger's sphere and to a responsible physician who actually examined my body. I wrote the Department of Consumer Affairs about the failure of the medical board. They sent me a document filled with fraud. Christina Delp, former director of enforcement, urged me to take this case of battery to police and DA, but law enforcement told me that medical battery is outside of their purview unless the medical board tells them to investigate. Since your board isn't doing real investigations, no one ever spoke to my doctor, they never saw my body. This puts your doctors above the law, and Californians suffer for it. Kim Kirchmeier, former executive director of the medical board and now DCA director, gaslit me. She called facts about my case my beliefs, which is a common tactic medical watchdogs do to invalidate malpractice victims. The gaslighting and denial of medical atrocities by your board is sadistic and it's cruel, and I'm asking you to stop. It greatly compounds the damage to malpractice victims. Many plastic surgeons in California violate people and cover up for each other. Your board acts as those surgeries that remove part of a healthy endocrine organ and are done for no justifiable medical reason and or include egregious assault are normal. They're not. They're crimes that cause a spectrum of problems. In May 2019, 45 of 55 members of the Los Angeles Society of Plastic Surgeons had multiple, easily searchable, desperate reviews. All liposuction-related deaths in Los Angeles from 1999 to 2019 were females, average age under 48. This is gender-related violence. Everyone in that room should be outraged and actually do something, but instead your board isn't holding these doctors to account. I ask that you learn the biology of fat. I've given you plenty of information, studies and whatnot, and the health structural and contour problems caused by liposuction. Stop gaslighting victims, stop bad surgeons, and stop medical scams. And I hope that the phone line is okay for the next meeting. And I don't know anything about the meeting, how long we can speak or anything. I'm in a lot of physical pain because of what Berger did to me. So if someone could please tell me, it would help because I certainly intend to participate. Thank you.
Thank you. Are there any additional comments on the phone?
Well, are you going to tell me?
It's on the board website. The details of the interested parties meeting is on the board's website. It's very clear.
Thank you. There's no further comments.
Okay. So we're going to return back to agenda item 17, update on from the Board of Pharmacy, Ms. Sodergren. I'd like to congratulate you as well for becoming the executive director as of yesterday.
Good afternoon, and thank you for the opportunity to provide an update on some of the Board of Pharmacy's activities. First, I'd like to thank Dr. Hawkins for his input and partnership in the regulations that the board adopted this week. Specifically, the board was statutorily mandated to develop emergency regulations under the provisions of SB 159, which deals with pharmacists providing PEP and PrEP. So thank you again, Dr. Hawkins, for your time. Truly appreciate it. And thank you to the medical board staff who helped to facilitate the communication. So thank you. The board has remained focused on its efforts to address prescription drug abuse and the epidemic. The board continues to offer day-long trainings to pharmacists and other healthcare providers that would like to attend. It includes topics covered include corresponding responsibility, prevention of drug losses, as well as things like naloxone training. It is a 6-hour training that provides free continuing education. In addition, we do have videos available on our website for those individuals that are unable to attend the in-person training. Last year, the first of the board's billboards that say "Use, Don't Abuse" were installed in Northern California, and we have 2 additional billboards that are planned for Southern California. The billboards reinforce the message to dispose of unused medications. The image of the billboard is also on the board's website, and if you click on it, there's provides a consolidated location for consumers to find information about prescription drug take-back locations, as well as information on prescription drug abuse prevention. In addition to the education, we have developed regulations that require inventory reconciliation activities and reporting requirements for all Schedule II drugs. This was really in response to the significant amount of drugs that were being diverted from pharmacies. During the board's most recent meeting, we are amending the regulations to include additional targeted drugs in addition to all Schedule II drugs that will also need to be subject to this inventory reconciliation activity. In addition, we recently adopted a policy statement to encourage pharmacies to report prescription drug diversion to law enforcement. So a lot of times what we find is pharmacies, the either licensed or unlicensed clerks or other pharmacy staff may be stealing from the pharmacy, but it's not always reported to law enforcement. So there's a policy statement in that area as well. In addition to that, in light of the significant proposed changes to several of the USP, I'm switching topics. In response to the proposed changes to several of the USP compounding chapters, last year the board established an ad hoc compounding committee. The committee dedicated several meetings to education of the new proposed chapters, followed by an assessment of the board's current board regulations governing compounding. However, in light of the appeals to the proposed USP chapters in late fall, the board has suspended its activities until additional information regarding the appeals is known, but the board will resume its activities when the outcome of the compounding chapters is known. We've also spent some time last year focusing on emergency preparedness and disaster response. This includes legislation last year that created a limited exemption to the Controlled Substances Security Form for displaced patients, which is one of the barriers that were identified during our post-event reviews. In addition, we now have a collection of online resources for disaster and evacuation planning. Our board will be going through Sunset Review this year. We did have the opportunity to submit our report in the fall.
Okay, thank you. Are there any comments from the members or questions? Dr. Thorpe?
Thank you for your comments and for your update, and congratulations to you as well. I'm a primary care doc in Northern California, and I am concerned about the increasing adversarial relationship between pharmacies and physicians and physician offices. I don't expect to solve that today, but I would be very interested in some kind of a future subgroup or some kind of a work group or something where we could work together to try to reestablish the collegial relationship we've always enjoyed before, and it could, because it's clearly not in the best interest of patients. So I just would ask that at some point we meaning the Board of Pharmacy and the medical community have some work group to kind of look at that, because there are some issues that need to be worked out.
I'd be happy to take that back to our board.
Okay, thank you.
Dr. Hawkins?
Thanks again. Good to see you. So just to chime in, fellow board member, I've noticed also in primary care that particularly chain pharmacists, they often talk about being overworked. They don't talk about being underpaid. They talk about being overworked, not having time, and appreciating the fact that they're forced to have a lunch break. But it seems like they're very, very, very busy. And I mentioned earlier, this is one of the concerns I had about, two concerns about pre-exposure prophylaxis, having to do with making sure that the patient or individual who would be prescribed those medications had a primary care doctor. And the other thing is whether the pharmacist had time to actually do some of the counseling, because these are real issues. One is the idea of every individual who gets these medications need to have a primary care doctor do the follow-up and the counseling, and just the idea about the some of the edge I feel, if not expressed, definitely feel by speaking to the pharmacist over the phone, particularly chain pharmacists.
Any additional comments? Okay. Thank you so much for your report.
Congratulations.
Yes. Are there any comments from those in the audience? Please come forward.
There are no comments on the phone.
Good afternoon. Happy New Year. I'm Dr. Khadijah Lang, President of Golden State Medical Association, and I wanted to speak with regards to the PrEP situation. The African American community are currently among the fastest growing groups of new HIV infections, so this is an issue of high priority to Golden State Medical Association. Increasing access to interventions that will actually prevent infection rather than trying to treat people once they're infected is definitely something that we're interested in. Our physician members are very interested and supportive of these methods to actually decrease the infection rate. However, there are some concerns that we have about this bill and its implementation. Specifically, we are concerned that this bill does not require pharmacists to test these patients for syphilis, gonorrhea, hepatitis B, or hepatitis C, all of which are infections that are of an increased prevalence in the population that qualifies for PrEP. So it is of concern to us that that is not being included. If they're going to do an HIV test, we would like to see them also get tested for those other things as well prior to starting the medication, especially because of the public risk that it exposes other people they're involved with when they say, oh, I'm on PrEP, I'm safe. And patients don't think in terms of, oh, yeah, okay, well, if you're on PrEP, you're at increased risk of HIV, which means you're also at increased risk of these other things. And patients don't know to say, great, you've got negative HIV and you're on PrEP, but are you also negative for these other things? So we would like to see the pharmacy board consider adding that into their bill before formalizing it, if it has not already been done so. The other thing that the bill does not make clear is what will happen if patients come in requesting this medication and do not have a primary care physician or a way to be put in contact with and under the care of one after that 60-day supply is up. Because the concern here is if we start these patients on the medication and then are unable to continue them on it, we increase the risk of them developing resistance to the drug, other people in the community getting resistance, and something people have worked and researched very hard to develop, and that has great potential, could be weakened. So we would like to see the situation of clear-cut follow-up with primary care established and documented in the law or the bill so that we really know how those aspects are being addressed. If I have a few more seconds, I'd like to just also ask, especially with regard to chain pharmacies, in the African American community and inner cities, we are continuing to have a problem getting patients controlled drugs once they have gone to a physician, been examined, gone to the pain management specialist, and then they go to certain neighborhood pharmacies and they can't get the drugs that are prescribed for them. While that same chain gives these drugs out very liberally in other communities. This is discrimination, and it is preventing patients from getting things. Wind up? Okay.
Time is up.
Okay. Thank you.
Thank you. Any additional comments in the audience?
Yes, hello, Dr. Ree here with Black Patients Matter. And so Dr. Lang, to carry that on, what she's stating, and I hope I'm saying this correctly, is that it is discrimination, and it works against underrepresented minority patients, and that hopefully it will be addressed accordingly. And we at Black Patients Matter, of course, wholeheartedly support Dr. Lang and her efforts, not just here locally, but her presence in D.C. with Congress, and all that she's been through. So we applaud her, and are just very humbled that she's able to attend this meeting here. Thank you.
Thank you. Are there any comments on the phone?
There are no comments on the phone.
Okay, great. Let's move to agenda item 18, update from the Department of Consumer Affairs, which may include updates on the Department's administrative services, human resources, enforcement, information technology, communications, outreach, as well as legislative, regulatory, and policy matters. Ms. Miller.
Hello, good afternoon. Thank you all for having me. My name is Brianna Miller. I'm with the Department of Consumer Affairs Office of Board and Bureau Services. Normally I begin my update with an introduction to Director Kimberly Kirkmeyer, but you all are very well familiar with her. So what I'd like to do is just jump ahead and start with summarizing Director Kirkmeyer's stated priorities that she shared with the department staff upon her appointment. And these priorities include the time frame for processing regulations, obtaining fiscal reports for the department, decreasing the time frame to perform investigations, working on ADA compliance issues, and also ensuring all legislation is implemented by boards and bureaus within the department. Director Kirkmeyer also endeavors to hold one-on-one meetings with all of DCA's boards and bureaus to learn more about goals and issues each is facing. As you may be aware, the department still has some vacant deputy director positions, including the chief deputy director position. So with that, Director Kirkmeyer looks forward to scheduling these one-on-one meetings once the executive team becomes staffed. I'd like to provide an update also on DCA's regulations unit. As you may be aware, DCA Legal Office recently created a regulations unit to directly assist in the processing of departmental rulemaking proposals. To date, the unit is fully staffed, and all DCA programs have been assigned a regulations attorney who will act as an assigned reviewer of proposed rulemaking packages. A large priority of the regulations unit is the processing of regulations to implement AB 2138. DCA, with the assistance of this unit, is proactively tracking the execution of all programs rulemakings with the goal of achieving full compliance by the deadline of July 1st of this year. Finally, another step DCA is taking to improve transparency and efficiency in the processing of regulations will be the use of Sharewell, which is a data system that will track regulation submissions and progress so that programs can monitor the status of their regulation packages upon submission to the department. The department is currently working on development of this system, and I look forward to providing additional updates in the future upon its implementation. Moving on to an update on Fiscal reports. DCA's Budget Office and the Office of Information Services are in the testing phase of a project that will allow programs access to budget expenditure reports on a similar schedule and to a similar level of detail as the previous CalSTAR reports that programs used to receive on a monthly basis. Staff are utilizing data that is extracted from Fiscal and combined with budget information in the QBERT system to create a monthly view of program expenditures compared against budgets. The plan is to release a new expenditure report in early 2020 for fiscal year 1920. Eventually, these reports will be able to run on demand through the QBERT system. Now I'd like to talk about required board member trainings and Form 700 filing, as it is that time of year. DCA has identified dates and locations for the 2020 board member orientation trainings. The first will take place on March 25th in Sacramento. Thereafter, we will host trainings in June in Southern California to allow members who are based in Southern California more accessibility to the trainings, and then again in October in Sacramento. As a reminder, the board member orientation is a required training for newly appointed and reappointed board members, and those who are newly appointed and reappointed must take the training within a year from that appointment date. DCA's Board Member Resource Center, located on the DCA website, has more information about the trainings and the registration form for those who would seek to sign up. In addition, 2019 was a mandatory sexual harassment prevention year. This means all employees and board members were required to complete this training. We thank you for your efforts in completing the training in accordance with the mandate, and we ask that if anyone has not yet completed, please do so as soon as possible. And finally, as I mentioned, it's that time of year for Form 700. Filings are due April 1st, 2020. Under the Conflict of Interest regulations, you as board members are designated appointees and therefore are required to complete a Statement of Economic Interest, Form 700. You are even required to file if you have no reportable interests. Departmental filers may use the NetFile system to electronically file. To create a NetFile account, or if you have questions about the account, you can reach out to DCA's Office of Human Resources. And if you have specific questions regarding your own filing requirements, you can reach out to DCA's legal office. And lastly, I'd like to just talk a little bit about DCA's Organizational Improvement Office. Used to be called Organizational Change Management Office, just to share a little bit about the program because we're trying to get the word out. The Organizational Improvement Office, or OIO, provides DCA programs change management services, business process mapping, information technology system requirement documentation. And in addition, it provides collaborative consulting on process reengineering that maximizes utilization of existing resources, improves productivity, and increases quality. Current projects being worked on by OIO include a review of DCA centralized services. OIO is currently conducting legislative mandated reviews of DCA services to achieve efficiencies. Those currently under review are Legal Affairs, Division of Investigation, Office of Information Services Services Desk, and soon Office of Human Resources. OIO also offers business analytics. They're working with 9 boards and bureaus to document and analyze processes. This work streamlines procedures, produces artifacts to help develop future IT systems, and creates new training tools. So that concludes my update. If there are any questions, I'm happy to answer them.
Thank you, Ms. Miller. Are there any comments from the board? Okay, thank you.
Thank you.
Any comments from those in the audience? Any comments? Okay.
There are no comments on the phones.
Yes, hello, Dr. Ree here, Black Patients Matter. I was expecting actually a longer presentation than that, but that was a good brief update. So in as far as there's this diversity training I'm hearing about that board members go through, and I would state to you all that it doesn't work. It's not working. It's not effective. I'm not sure what is being discussed or what the training is, and I state that because our most recent federal civil rights lawsuit that we filed was against an unnamed board member who wasn't clear on the difference between race and ethnicity. We of course love and embrace and support our Hispanic brothers and sisters, but being Hispanic is not a race. So that's why I would postulate to you all that this diversity training is not working. So in which case, the most obvious, simplest step would be to retain and appoint board members that have experience, diversity and religious tolerance experience, as evidenced on their resume. Thank you.
Thank you. Are there any comments on the phone?
There are no comments on the phone.
Okay. Moving to agenda item 20, because we've already gone over agenda item 19, update and possible discussion and action from Midwifery Advisory Committee, Ms. Holzer.
Hi. Thank you. I'm Diane Holzer, licensed midwife and chair of the Midwifery Advisory Council. I'll just say MAC for that. So we're asking the board to please approve the following agenda items for the next MAC meeting. Establishing goals for the MAC. We've decided just to put that as a standing agenda because we're always figuring out new things to do. Update on midwifery-related legislation. A report from the MAC chair. Update on the midwifery program. Report from the task force and discussion regarding the data collected on the licensed midwife's annual report. A report from the task force on recommendations to the board regarding vaginal birth after cesarean legislation. Meeting dates for 2020. Discussion on revisions to the practice guidelines for California licensed midwives. Selection of a new MAC member, one midwife position. And discussion on how the MAC will prepare for future fall medical board meetings when legislation is proposed. And that's mostly just around when, if we might want to change our dates in relation to the medical board dates. The background, the last MAC meeting was held on December 5th, 2019. At this meeting, the following actions were taken, or the MAC was provided the following information. We created a task force to work on recommendations to the board regarding VBAC legislation. We created a task force to determine if additional data should be collected for the LMAR. We received an update on midwifery legislation and an update on the midwifery program. We received an update on the LMAR analysis of data and issues. We discussed various goals for the MAC. We received a report from the task force on Medi-Cal-related issues. We received a report from the task force on revision of the guidelines for midwives, and we received a report from the task force regarding challenges obtaining Social Security numbers and electronic filing of birth certificates.
Thank you. Yes, we're looking for a motion to approve the agenda for March 5th, 2020 council meeting.
So moved.
Okay, great. Ms. Cruz-Jones? Do we need to go to the public comment? Okay. Comments from anyone on the panel? In the audience?
I think everybody would like to say, oh, can I say something?
Related to...
This lady, she's fabulous. I didn't know she was going to be here. Can I say something? Yeah.
You can. You can.
I want to say it. You have no idea how worlds converge. It's really fabulous. I came here today as a favor to a friend who couldn't come because of her severely autistic son. And I walked in here and I see Diane Holzer, and I haven't seen her in quite some time because she delivered my third child when I was living in the Bay Area before I was displaced by the Tubbs fire. So whatever these midwives want, please give it to them. Whatever they are about, please honor them, because the kind of midwifery care this woman gave, I couldn't, 3 minutes would not suffice. She and her midwife colleagues are so fabulous. So whatever she needs, please honor it. And I'm just sorry that the 8-year-old that was, caught, thankfully he didn't fall on the floor, because I wasn't in a position to catch him. I wish he were here in the room because you don't know how these worlds are going to converge. And I just love this woman and all of her colleagues to the bottom of my toes and the tips of my head. And this isn't a script. It's just me saying we never know, right? She caught my third kid, or maybe it was Joan. There were 3 of them in the room. And I told her in the lobby just now, I saw colors that I didn't know existed. And so to be here today thinking I'm going to see, I'm going to do this favor for this friend, and to see this midwife is just so beautiful. So I just want to give a moment to acknowledge that, because whatever those midwives want, please give it to them. They're fabulous. So that's my spontaneous comment. And I don't need to use up the rest of the 1 hour, 1 minute, 15 seconds. You get the point. All right. Thank you. And thank you, Diane. I love you. And Joan and Leah and all the other midwives. Thank you.
Thank you. Any comments on the phone?
There are no comments on the phone.
Okay. Ms. Cruz-Jones.
Dr. Gonadev. Dr. Hawkins.
Yes.
Dr. Kraus.
Yes.
Ms. Lawson. Ms. Lubiano.
Yes.
Dr. Lewis.
Aye.
Dr. Mahmood. Dr. Thorpe.
Aye.
Mr. Warmoth.
Aye.
Mr. Watkins. Aye. Ms. Pines.
Aye. Okay, the agenda is approved. Let's move to our next agenda item 21, an update from Ms. Robinson on the strategic plan.
Good afternoon, President Pines and members. Please turn to my.
No.
The light's on? Oh, okay. I was told I project pretty loud, so I always have to adjust when I start. Good afternoon. Please turn to page BRD 21-1 in the board packet for the 2019 strategic goal highlights. This is my second update on the board's 4-year plan. The plan is guided by the board's mission of consumer protection and is organized into 5 goal areas: licensing, enforcement, legislation and regulation, outreach, and board administration. I will not go over all of the accomplishments listed in this report, but would like to highlight some of the most important. In licensing, the board launched the new postgraduate training license in Breeze and revised all other forms, policies, and procedures for the changes to postgraduate training and licensing requirements effective January 1st, 2020. This month, the board launched the new Docs portal system that is being used to electronically receive verification documents from medical schools and postgraduate training programs for physician and surgeon license applicants. To improve efficiencies and reduce the number of paper renewal notices being mailed, the board began sending electronic courtesy renewal notices to physicians 180 days prior to license expiration date. This has yielded savings on postage costs, because if physicians renew more than 120 days prior to the license expiration date, the board will not mail a paper renewal notice. In enforcement, board staff improved the enforcement process to decrease the time by when complaints are reviewed and investigated. The board conducted 4 8-hour interactive expert reviewer trainings to improve the quality of expert opinions. The board also hired a chief medical consultant who, in addition to other duties, will assist with the expert reviewer program. The enforcement program revised the complaint form so that adequate information is received. This enables staff to act on complaints without taking extra time to request additional information. Board staff met with physicians impacted by the Patient's Right to Know Act to educate them on the new law requiring physicians on probation for certain offenses to notify their patients of their probation status prior to the patient's first visit. Pursuant to this act, the board also added detailed probation summaries to the board's website in order to explain why a physician is on probation. In legislation and regulation, the board launched a pending legislation page on the board's website, outlining the legislative bills the board is monitoring and how consumers can engage in the legislative process. The board continued to work with lawmakers to help craft laws that enhance consumer protection and held its annual legislative day on May 15, 2019. The board also produced and posted on its website a podcast entitled A Look at the Board's Role in the Legislative Process. In outreach, the board published and posted on the board's website a new consumer's guide to the complaint process. The board created a new feature in the board's newsletter dedicated to consumer information. The first article provided readers an overview of the board's complaint process and what to expect when a complaint is filed. Other articles provided information on outpatient surgery settings and ways to see or receive copies of your medical records. The board also launched the Volunteer Physician Registry. Physicians provide information regarding where they would be willing to volunteer and details about where their area of practice and foreign language proficiency. Clinics and other entities use this online registry to connect with volunteers in order to allow these physicians to provide services to patients in these areas. In board administration, the board secured an increase in the hourly rate for trained medical experts that became effective July 1st, 2019. Executive staff and enforcement managers collaborated with the Food and Drug Administration to suggest the provision of more detailed information on warning letters so the board can investigate them for potential violations of the Medical Practice Act. Board members attended staff events, including all staff meetings and the board's annual employee appreciation picnic. In looking ahead, this year the board will work to reduce enforcement timelines, review additional license types needed online, revitalize the board's expert reviewer program, develop educational podcasts, foster relationships at the annual legislative day at the state capitol, and begin the sunset review process. This concludes my update on the strategic plan.
Thank you, Ms. Robinson. Are there any comments from or questions from the members? Okay. Thank you. Marianne Hollingsworth.
Good afternoon. My name is Marian Hollingsworth, and I'm a patient safety advocate. I would like to comment on your vision to be the premier consumer protection agency leading the effort to advance high-quality medical care. While I applaud this goal, you have a long way to go to earn that title. First, this board rarely follows its own disciplinary guidelines when doctors have harmed patients. In fact, most of the disciplines handed down lately are below the guidelines. So let's talk about some of the major issues you need to focus on to be considered a premier agency. One is maternal mortality. This board has a history of being lenient on doctors involved in childbirth deaths. For example, the minimum recommended discipline is 5 years probation for gross negligence. Yet Dr. Arjang Naeem was found responsible for the death of Kira Johnson, who literally bled to death after a botched C-section. Naeem also had 2 near-death hemorrhaging cases before and after Kira's, along with 3 other harmed patients, and all had bleeding issues. He just got 4 years probation, a year less than the minimum for 6 harmed patients. Dr. Longdae Liu of Garden Grove was also found responsible for the bleeding death of another young woman in childbirth, and he just got 35 months probation. You also have childbirth death cases pending from 2013. These doctors are still practicing with no limitations while you decide. And then there's a board track record on sexual misconduct cases. You had had an increase in complaints of more than 60% in the last 2 years, yet your discipline rate fell by 28% last year for sexual misconduct cases. There were 279 complaints last year, but only 15 disciplines. And a third of those doctors are still practicing. How is that being the premier consumer protection agency? The rest of those complaints cannot be considered frivolous. It seems that cases involving harm to women are not taken seriously or not seriously enough to warrant giving doctors at least the minimum recommended discipline. And then there's the issue of reprimands. All too often, egregious cases, including deaths, just result in a reprimand for the doctor. This includes the case of Dr. Daniel Hedrick, who was allowed to plead down to a simple reprimand in the overdose death of 20-year-old Alex Smick, who was a patient in Hedrick's rehab clinic. His case took more than 4 years to complete. A premier agency would not let these cases happen to consumers they have sworn to protect. You must improve how you deal with complaints about dangerous doctors if you are really concerned about high-quality, safe medical care. You must be willing to listen and acknowledge your shortcomings in order to improve patient safety. Thank you.
Thank you. Are there any comments from the public?
Y'all need some kind of special glasses if you can't see that some of the vision written about in this report is blurry. To be the premier consumer protection agency leading the effort to advance high-quality, safe medical care. First of all, that's not hard since all of the medical boards in this country are sorely lacking, as was reported in the Consumer Reports in 2016. Lisa McGifford is quoted as saying, "We found that most medical board websites don't make it easy to find profiles on individual doctors, and when you get there, you don't get easy-to-understand explanations of what, when, and why the board took disciplinary actions." While California scored the highest of the medical boards, the scoring in the report is like comparing 50 mass murderers. One is always going to come out as the least worst. It's odd how this board always reports about all the wonderful things they're doing, but they don't report when they screw up. Why is that? Why has this board never addressed the fact that recently one of your own medical reviewers did things so wrong and unscrupulous the Attorney General's office had to recommend that the complaint against the doctor, who has harmed a number of patients, be dismissed, which it was. It turned out that the expert was a direct competitor of the accused doctor. You don't report on this stuff. Is only talking about your skewed accomplishments and hiding your failures really doing a service to the public, or just yourselves? In instances like adding the probation summaries pursuant to SB 1448, you take one step forward and one step back. Has anyone even looked at these to see how tiny the font is? Julie D'Angelo-Felmuth and I both complained about the website font size at the October 2017 meeting. It's in the minutes. And you've still not done anything about it. It's an easy fix, people. There's no excuse for not making the website easy to read, especially for people with vision problems. Here's another one step forward, but it's not even a whole step. You've created a consumer's corner in the newsletter. I hope because I complained that there isn't one. But out of 3,872 square inches in the newsletter, you devoted 132 to consumers. That's a whopping 3.4% of the entire newsletter for consumers, even though your mandate is to protect consumers. And it's not even indexed on the front page. Over 96% of the newsletter is geared toward doctors. Do you see the similarity between that and your actual protection of consumers? 4% disciplinary rate, 3.4% devotion to consumers in the newsletter. And lastly, it's very telling in the looking ahead section. You're interested in fostering relationships at the annual legislative day at the state capitol, which is really just a photo op day for the board to pose with legislators. And advocates aren't invited to make sure that you're saying things in their best interest, but you're not interested in fostering relationships with the public and advocates. Your chosen words are very telling.
Thank you. Any additional comments from the public? Any comments on the phone? Please come forward.
No comments on the phone.
Dr. Khadijah Lang again from Golden State Medical Association. I'd like to thank Ms. Robinson for her report and the work that she's done. We appreciate that. I'd also like to thank the medical board for the work that was done several years back for the demographic study that California Research Bureau did. For those of you that are new to the board or are not familiar with this, since it started in, I believe, in 2013, the Charles R. Drew Medical Society of Los Angeles started coming to the board, bringing this issue up. Subsequently, Golden State Medical Association joined in the concerns as we saw the problem was statewide. And basically, we brought concerns about the demographics of physicians being impacted by the medical board. And as a result, the medical board agreed to have California Research Bureau do a study. Their study found that African American physicians were had a 1.4 rate of disciplinary and accusations from the board. Latino physicians was 1.6. That translates into 40% and 60% respectively, just by virtue of a physician being African American or Black. With that in mind, we feel that it's very important. We're happy that the study was done. We feel that it's important that these efforts now be followed up, because the disparate treatment of African American and Latino physicians is harmful to the public that we are trying to serve and protect here. We would like to get an update and some follow-up on how things are going with the implicit bias training, whether or not it's actually working. We'd like to find out if it's possible to do any type of study to look at that, to make certain it doesn't need any additional work or revisions so it can be even more effective. We would also like to know whether or not there is a possibility of getting a repeat study done, demographic study done, so we can see whether or not the interventions that have been put in place thus far are helping to make a difference, are really impacting the concern that was addressed, and how we can go working together to make certain that this does happen in a timely manner. Lastly, we would like to ask that, given the fact that so many physicians of these ethnic groups are being impacted disparately by the actions of the medical board, we'd like to ask that the medical board collaborate with our organizations to provide programs and support those programs to educate physicians in the communities that are most impacted by this about things such as medical record keeping, ethics, the frequent violations that physicians are frequently called up on. We'd like to ask that we do something preemptively and start getting educational programs going so that we can make certain that these physicians get this. I am aware of the fact that we're currently trying to get the accreditation for medical schools, AAMC, to try to start getting this training into medical schools and residency programs. So far, it's a long way off. However, we feel that in the interim, for those physicians who hopefully will never be going back to medical school or residency, but are still at risk of having their licenses impacted, we would like to start some educational programs with cooperation and support from the board. Okay, thank you very much.
Thank you. I think I heard that there was no comments on the phone. Was that correct? Okay, perfect. We are now at the conclusion of the board meeting. Oh, okay.
So thank you, Ms. Pines. Just to continue what Dr. Lang was saying, I think it's outstanding for a physician to come here, a renowned leader within the community, to come here and say, hey, we want to be proactive. Come engage with us and discuss what concerns you have about record keeping and what can we do. I mean, that's just outstanding. We don't have, right? I mean, we don't have physicians coming in here and being proactive. Now, speaking of proactive, for myself, even though I took 3 PACE courses proactively before my hearing, I said, boy, when I got to the PACE courses, there was almost all of them were racial minority physicians. And so I can see I saw the disparity. So I think it's outstanding that we have a physician from the community, a leader in the community, come and reach out to you all, to engage you all. It's just outstanding. So the demographic study, I think it's wonderful that we have that. We have this implicit bias training, but we at Black Patients Matter, we want to see more. We believe that the implicit bias training is not effective enough. In fact, it's important to start utilizing contracting with physician experts who have that diversity experience, sat on boards, worked in communities, have seen patients of a certain percentage underrepresented minorities, because the way it is right now with your 800, 900 medical experts, most of them come from clinics who are white only, just from the demographics of it, and certainly probably not from the choice. Okay, so that's it. Thank you very much.
Thank you. Moving to agenda item 22, future items on the agenda. Do we have any board members that would like to add a future agenda item? No? Okay. Are there any comments? Well, there's no future agenda items, so there's no comments to make on the future agenda items. Okay.
You know, I think I stated this already. I keep hearing about the implicit bias training, and to be quite honest, as I stated before, you know, I really feel bad about filing another federal civil rights lawsuit. So I would like to maybe see, what is this implicit bias training? I kind of want to, you know, so I would like to have that be an agenda item. Like, what are you teaching? That, you know, what's going on? Is it enough? Is it, you know, that kind of thing? Thank you.
Just real quick, just to keep my record going, I know I know Carrie thinks it's none of the board's business, but I'd like for it to be put on the agenda that we talk about the Public Record Act.
Thank you. Any other comments in the audience? Any comments on the phone for future agenda items?
There are no comments on the phone.
Okay, great. Oh. Mm-hmm.
I would like trauma-informed care training for doctors on the agenda.
Okay.
Didn't hear you. Well, now you can. Trauma-informed care training for doctors on the agenda, please. Did you hear me now? Trauma-informed care for medical professionals. That's it.
Okay. Thank you. We are on the final agenda item, which is adjournment, item 23. So there's no further business with regards to the board meeting today. However, we do have a interested party meeting that's following immediately after this. We're going to just take maybe a 10-minute short break just to reorganize the room a bit. So if we can ask everyone to step out so we can organize the room, and then we'll invite you back in. Thank you.